Yeah, and all right, if you guys are ready, you get
Yeah.
3:12. Okay. Yay, everybody's filtering in. As you filter in, I just want to say a huge welcome. Dr. Dempsey and I are so excited to be here with you wherever you're at in the world. For us, it's early evening for me, a little later evening for you, Dr. Dempsey. And we're so excited to talk about this topic because there has been so much interest on in the media and social media, really in everything. And so I think we're going to really dive deep and hopefully help you understand. A couple little housekeeping things before we get started. We are not here to give specific medical advice. While we are both medical professionals, we are not replacing your doctor. And there will be some questions that we may not be able to answer for that reason, but we're going to try to be deep and be very transparent and give you a lot of really practical information. I also just want to introduce Dr. Dempsey, who is a colleague and friend and just someone I deeply admire for her research. We'll dive into just a little of her story and getting into mast cell and all of this. And Dr. Dempsey, do you want to say just a minute and introduce yourself?
Well, sure. Thanks so much, Dr. Jill. I've been really looking forward to this, right? This is so much fun. We always have fun
I know.
together. So I think this is a great opportunity for us to pick each other's brains, right? And also share what we know with our listeners and audience. What should I tell you? Want me to start with my story or you want me to start
Well,
with
I just kind of want people to know who you are, where you practice, what you do, and then I'll do the same, introduce our sponsor, and then we'll jump right in.
Okay, so Dr. Tania Dempsey. I work in Purchase, New York. I have my own center there called AIM Center for Personalized Medicine, where we are really a destination practice. And we have several different practitioners, including Dr. Lawrence Afrin, who's really the world's expert in mast cell activation syndrome. And we're doing some really exciting stuff now in our practice that I'm like excited to share. We're doing therapeutic plasma exchange or plasmapheresis. We have lots of new IVs that we've brought in. We have the Balancer Pro lymphatic drainage suit. We have the Nano V, which is a breathing
Yeah.
device that you breathe in structured water that has like some really cool, interesting research. So my goal with this, my practice and as a whole is really to provide patients with the best quality care they can get anywhere, and also to provide them with options that we know our complex chronic patients are not all the same. The same protocol cannot work for everybody, and I just want to be able to provide everyone with options to address their underlying issues. So that's my story.
Awesome. And it's so cool to hear all the amazing things you're doing. I'm in Louisville, Colorado, if you guys don't know, near Boulder. And I do functional integrative medicine. I have a nurse practitioner and a PA. We are accepting patients. And we, similarly to you, trying to really broaden the ability to reach patients. And this is one reason I love getting out here with all of you who are on this webinar tonight, because we get to reach out to you and connect with you and hear what your questions are. So just another little housekeeping. I see you guys saying hello. So just jump in there, the chat, say hello, tell us where you're from. We would love, it's so exciting to see
Okay.
Vancouver, New Zealand, Michigan, Parker, Northern Colorado. Hello, hello, hello to every one of you on this. Pop in, say where you're from. It's really fun to be such an international audience as well. And then,
Well,
like I said, if you have questions, pop those questions into the Q&A because that way at the end, we're going to stop a few minutes early with our kind of back and forth lecture here. And then we'll try to get to as many questions as we can at the end. So stay tuned for that. Lastly, I have to reach out and just honor our sponsor. Silver Genetics is our sponsor tonight for this incredible show, masterclass. And they are a new company that's doing autoimmune genetic testing. You can find them at silvergenetics.com. And they have a silver helix nutritional genome test. So if you want to know, like your mast cell activation syndrome is out of control and you're trying to figure out what other genetic components are part of this and what is making you more sick or more inflamed, a lot of times those little genetic, unique pieces of yourselves, it's kind of like why Dr. Dempsey and I do personalized medicine. At least for me as a doctor, I can see, oh, this patient really doesn't break down histamine, or this patient really, really has trouble with methylation. And those little clues in the genetic code code, tell us why you're uniquely responding how you are. So check that out. And the sponsor has given us a code, just Dr. Jill, to get 15% off your first test. If you're interested, you can go direct. It's direct to consumer, so you don't need a doctor's order. Again, that's Silver Genetics. And I just want to say thank you so much for sponsoring us tonight. Okay, so Dr. Dempsey, let's dive in. We've got amazing group of people tonight from all over the world. And first, I just want to talk about mast cell activation. Many people who are here know what it is, and that's why they're here. But for those who maybe don't know or haven't heard about it, what is it and why is it increasing in incidence? Why are you and I becoming experts in this field?
Yeah, wow. It's very complicated, but let's start a little bit from the beginning, right? Just to give everyone sort of the same, sort of same starting point in case some people are more newer to MCAS, and for those even, it could always use a refresher, right? So the mast cells are part of our sort of primitive ancient, a primitive or ancient immune system. We call it the innate immune system. We have two arms of our immune system. I actually have a few others, but like we usually categorize them as innate, which is the primitive, and then adaptive. And adaptive includes like the production of antibodies and things like that. So the first line of defense is your innate immune system. And those mast cells are basically everywhere in your body where they're in contact with the environment. If they see something, it could be something you ate, it could be something that you breathed in, if it's something that touched your skin, whatever it is, the mast cells can react. And the way it reacts when it thinks something is bad or poison is it releases various chemicals or mediators, we call them. There are over 1,200 different mediators actually that mast cells can make. A lot of people know about histamine, but histamine is one of like 1,200. And mast cells also have like these receptors on their surface that allow them to interact with the environment. Various receptors that help them, something will bind to it, and that will send that signal. So the point is that everyone has mast cells.
Hmm.
Everybody's mast cells will react at some point in their life. I like to use the example of things like COVID or the flu or whatever, right? If you don't have mast cell activation syndrome and the mast cells, see that virus, they will go into action, right? And they'll start releasing lots of chemicals, and that's part of the stuff that you deal with, like the congestion and a cough or whatever else. But in people who don't have the activation syndrome, after the infection is gone, it will um, kind of go back to normal. They'll reset, let's say. I'm being told that they can't hear me.
I
Can
saw that,
everybody hear
but
me?
let's do
It
tech.
was just one person, and I did let
Oh,
them know that the
Okay,
replay.
yay, I see
I
I
can hear you.
can.
Let
Thank
me
you,
interrupt
guys.
you.
okay,
But I
Yeah,
okay.
thought so. I
I want
think
to
we're
make sure.
good. Yeah,
Yeah.
yeah,
I don't
good.
want to keep talking if
No, you're
people can
great.
hear me.
It's great.
So in any case, so again, normal person has no, you know what I mean, not
Yeah.
normal, but someone who doesn't have this condition, their mast cells react, their mast cells go back and rest after they're done, and they just wait for the next attack. Okay. We know mast cells are involved in allergies. We know some people have allergies, but that's not necessarily activation syndrome. Activation syndrome is when the mast cells at baseline are a little bit more activated. So they're leaking these
Yeah.
chemicals and causing local inflammation and systemic inflammation. Then they're hit with a trigger. Maybe it is COVID. Maybe it is something in the environment, some kind of chemical. Maybe it is stress. Maybe, I mean, the list is tremendous, and we'll go through a lot of these, I
Yeah.
think, if we can. But the reality is that because their mast cells are um, already in that state of activate, like mild activation, that trigger takes them to another level.
Yes.
And then the mast cells are overactive and reacting, and sometimes reacting to things that are like not something that they should
Like
even
heat
react.
or cold or sauna or food or things that like would normally, like you said, there's, and we can name a bunch of those triggers, but
Yeah,
it's interesting because it's often things that shouldn't necessarily bother you, right?
exactly. Or even the sun,
Yeah.
like people
Yeah.
go out in the sun.
Yes.
So the definition of mast cell activation syndrome is really inappropriate release of mediators
Hmm.
from the mast cell. And when they do react, part of the problem is that they don't go back down to baseline,
Yeah.
which is where other people's mast cells go. So there's now often a new baseline.
It's like a new higher and higher and higher threshold. Yeah. Yeah.
Exactly,
One of the,
exactly. Yeah, go ahead. I'm sorry.
I was going to say one of the things that you were part of was the consensus two statement on mast cells. And we'll be sure, and anyone who's, first of all, people are asking about recording, you're going to get recording. Anyone who signed up will get it. So stay tuned. If you can't stay the whole time, no worries. And back to the paper. So this original paper was on how do you diagnose? And I think it's important because a lot of doctors who maybe know a little bit about mast cells will say, well, let's check your histamine or let's check tryptase, right? These two that are really commonly used in blood. And the truth is there are hundreds, if not thousands of mediators that can be tested and well, not all can be tested, but that can come from mast cells. And just those two alone are not always a good test of this whole big syndrome. So I wanted to frame that in the sense of I love that paper because it really brought light to there's many different ways that we can diagnose. And if you want to go through that, like how would someone know if they have it?
Yeah. Look, I think I think it's important to emphasize that you need the clinical, picture of
Yeah.
it, right? And sometimes patients can only be diagnosed clinically
Mhm.
because we can't find the mediators. So they have to have a clinical picture that's consistent with it. And then there are these various mediators that we can test in the blood and in the urine and even use a biopsy of that can be stained to look for mast cells, like from a
Yeah.
colonoscopy or an endoscopy. And we are looking for two pieces of laboratory evidence. Um, it could be a biopsy positive, it could be a urine mediator positive. So basically, we're looking for two. And then that would qualify for our consensus two criteria for mast cell activation syndrome. What's really interesting is probably one of the most common mediator that I see in my practice is a heparin level,
Mhm.
elevated heparin. And it turns out that mast cells are the only cells in the body that make heparin. Heparin, for those of you who don't know, is a blood thinner. Actually, there's a commercially available drug, heparin. It's given in the hospital very often for blood clots. And then it turns out that mast cells can release these small amounts. If you see heparin in your blood, unless you're taking heparin as
Yes.
a drug, it is a very sensitive and specific marker for mast cell activation syndrome. Of course, we have a lab that we work with because it's often very hard to detect. But that's actually one of the things that I think is a little bit even more relevant for lots of patients, especially those who don't have elevated histamine,
Right.
have elevations of the easier things to
And
test.
because this is like a yo-yo, right? You have times when you're activated and you're very much under these mediators and times when you don't. And so the testing can be tricky if you've been told by your doctor everything's normal because it might only go up when you're having a reaction. And the way that these things are, need to be, very kept very cold, for example, or transported very carefully. There's a lot of variability and a lot of error proneness because these tests are so prone to being done poorly, right?
Well, these mediators are very, very short-lived. They
Hmm.
get
Yes.
degraded very quickly,
Hmm.
and they're thermolabile, so they're sensitive to heat.
Hmm.
So the minute a specimen warms up even a little bit, like the patient could do everything right. The specimen gets to the lab.
Yeah.
The lab tech puts it on the counter just for 5 minutes,
Yeah.
10 minutes before it puts it back in ice, before they put it back, and
It's
already
done,
that
right? Yeah.
probably
Yeah.
result in a negative. Yeah.
I love saying that because then again, if patients are asking their doctor for tests, first of all, I put the link in the chat so you can see the link to the paper that you were an author on for the consensus too. So if you want to read technical, it's there.
Yeah.
But also often, again, it is kind of hard to diagnose with these tests because they're so variable. So clinically, let's shift to that. What are people looking for symptoms? We talk about this as a multi-symptom, multi-system disease because it affects multiple systems, multiple symptoms, and that's also part of the diagnosis. What different systems are affected, and each of the symptoms, what are common symptoms?
Yeah. So, it's again, it's every tissue
Mhm.
organ in the body has mast cells. Mast cells are white blood cells, but they don't circulate in the bloodstream. Well, they do very briefly. They're released from the bone marrow, they go into the bloodstream really quickly, and then they land in the tissue. And that's where they're trying to protect you, right? So they're in the skin, the respiratory tract, the GI tract. they're in the nervous system, they're in the genital urinary system. And so, depending on where they are and where they're releasing their mediators, you'll see, a variety of different manifestations. So, I think of it like in the skin. You can see a whole host of different symptoms. It could be itching, could be hives, could be itching and hives, could be different types of rashes, could be eczema, could theoretically be psoriasis. So skin manifestations are, I think in some ways maybe a little bit easier to understand and to find. Then there's allergic symptoms in the respiratory tract. You don't need to have true allergies to have allergic symptoms, and you also don't need allergic symptoms to have mast cell activation syndrome. So my favorite example is, patients who have gone to allergists, they have clearly certain times a year or even maybe year round, they have runny nose, they have maybe they have asthma, maybe they have congestion, they have itchy mouth when they eat certain foods, and they go to the allergist, and the allergist says, there's no allergies.
Yeah.
So this is
Yeah.
impossible,
And I
right?
see people in the chat. I just want to acknowledge you guys. You're like, why aren't, ERs and places and doctors and hospitals are missing this? And you're right. I kind of want to acknowledge that, which is what you're saying, Dr. Dempsey, because many, many doctors don't, we're taught mastocytosis, which is proliferation in a bone marrow of a disorder that's actually quite rare. And this whole thing was not even, it's starting to be taught, but at least in my decade of training, we weren't really taught this in medical school. So a lot of you are coming encounter with doctors who have no clue that this exists. And so I'm sorry for that experience for all of you, but that's very, very common. Keep going, Dr. Dempsey. I just want to acknowledge this in the chat and all of you who have
Uh,
suffered and not been able to find a doctor who understands.
Yeah, no, 100%. I have this on my website. I have a systems, I think it's
Sheet.
a chart or a list
Yeah.
of all the different symptoms in every organ system. So, right. So again, if you get a no from a doctor, but something's wrong,
Yes.
keep keep looking,
Mhm. Yeah.
find your partner in the medical world that's going to help you navigate this and try to figure it out. So again, allergic symptoms certainly, chronic cough, and then in the GI tract, reflux, very, very common.
Yes.
Think about reflux that happens almost immediately after eating something. Well, that's a little too fast for it
Yes.
to be true reflux.
Hmm.
So that suggests a mast cell driven, phenomena. Things like a slow gut motility, gastroparesis can definitely be associated with MCAS, constipation, diarrhea. IBS, we'll say, even IBD, inflammatory bowel disease,
Hmm.
has been linked to mast cell activation syndrome, and there are several studies in the literature supporting that. But again, like we can keep going, and the symptoms are just, hundreds, thousands, tens of thousands,
Yeah.
probably. In the GU tract, we see vaginitis, we
Mhm.
see vulvodynia, we see prostatitis, we see heavy bleeding
Mhm.
for women, abnormal menses, we see hormonal issues very, very often, hormonal fluctuations that cause sometimes mood disturbances. So in the nervous system, we see potential for anxiety,
Mhm.
depression, OCD. It can present as a PANS or PANDAS, autoimmune encephalopathy type picture.
Yeah.
Um, and and in those cases, for me, what I say all the time is that that's a physiological problem. That's not a mental illness.
Right. Right.
Is something in your body causing the release of these chemicals, which is irritating the nervous
Mhm.
system, which is leading down the path of these symptoms.
Yeah.
So it's really, yeah, I
There's a
could,
lot of papers. I saw someone in the chat mentioning neurological, so like migraines, very, very frequently related to mast cell activation. And then, as you mentioned, Dr. Dempsey, mood disorders, depression, anxiety, bipolar, even schizophrenia in the literature has been linked, all kinds, insomnia. You name the mood disorder, there's a link to mast cell. Not that everyone with those mood disorders has mast cell, but many patients do, and they're treated with SSRIs and maybe they don't get better because the underlying issue is histamine mast cells and these mediators that are affecting the brain, because a lot of these mediators are so small, they go right into the bloodstream, into the brain, and affect our cognition. So it's really common to have neurological manifestations as well. And Dr. Dempsey, you alluded to pain syndromes. There's a whole, actually several papers, one in particular I often present on that just talks about just the pain manifestations of mast cells. So some people with chronic pain, unresolved pain, vulvodynia, all the things you mentioned, and neuropathic pain.
Endometriosis, et
Yes,
cetera. Yeah, that paper you're
yes,
referring to is a really
yes, I
great
exactly.
paper. Was published by Larry Afrin,
Ah,
and it really is. It walks through that
yeah.
pain pathway and how
Yeah.
the mast cells are
It's a
involved.
big aha because a lot of people, and I will find in my clinical practice, sometimes the most mysterious, difficult patients, not difficult is it's hard, like I don't mind them, but most doctors don't know what to do with them, right? And in that sense, I love taking them on, and so do you. But in those patients, I often find there's a mast cell component. I'd say maybe 80% in my
Oh,
clinical practice, right?
mm.
So we've talked about kind of the
Maybe
systems,
90,
yeah, maybe
95%.
90. I know, right? Honestly, in my practice too.
Yeah.
So we talked about kind of like what this might look like as far as symptom systems, and Kyle's been so great to throw in the research and throw in your website and all that. Let's see, Kyle, I also have a blog on psychiatric manifestations that you can link there, and I think it has some of your colleagues' research in that paper too. Let's talk
And we
then.
just
Yeah,
published actually, let me pull it up.
yeah, please, because yeah, maybe while you're and you can pop it into the chat too, just to
We
everyone.
just published with
Mhm,
Dr. Lenny Weinstock, Larry Afrin,
mhm.
and I think Svetlana. I'll find we did a like a survey.
Mhm.
I'll find it literally was just published, but
Good.
I
Well,
think
while you look for that, I'll go. So we've just kind of covered the overview. What is mast cell? And I love your comments in here, guys. Please keep throwing them in there because so many people are giving this doctor help, this doctor didn't help. This is what happened with me, and it's really kind of neat to see what you guys are suffering with. And I'm sorry that some of you have not gotten help with this because it should be the standard medical education, and hopefully Tanya and I will continue to bring this forward as she keeps publishing papers. Okay,
yeah,
but
I found it. I'm going to
okay,
just
perfect.
mention it too. It's the prevalence and treatment response of neuropsychiatric disorders
Yes.
in mast cell activation syndrome.
Perfect. Oh
And I
yeah,
can
drop
put
that in
that
the
in.
chat if you can. That's great.
Yeah, yeah,
So
yeah.
before we talk about GLP-1, which I promise we're going to get to shortly, I want to just talk about the chronic immune dysfunction, inflammation, and maybe some of the triggers. Because what Dr. Dempsey and I see in clinical practice is these mast cells go awry, right? And there's genetics that lead certain people to be more reactive than others, but there's also many, many environmental triggers. And I always frame the functional medicine paradigm as toxic load, infectious burden. And these two players are the biggest two that I see that are driving these inputs to create dysfunction in the immune system. And so I'd love Dr. Dempsey to talk a little about some of I heard a lot of people saying, does Lyme connect to this? And Epstein-Barr, they're asking those questions about infections. And then, of course, my thing is toxic mold. I could talk just a little bit about that because I think the number one trigger of mast cell activation that I see is toxic mold. But do you want to frame what do you see in your clinical practice as far as things that drive some of the mast cell activation?
So, what I think is important is just to back up a little bit and think about it as we mentioned earlier, almost like a progression of mast cell activation syndrome,
Hmm.
right? So, a lot of people think, let's say, Lyme triggered their mast cell activation syndrome, or COVID triggered their mast cell activation syndrome. My experience, anecdotally, and we're trying to publish some of this, really is that most of these patients have a susceptibility to it, to
Yeah.
mast cell activation syndrome. Then they've had a series of triggers over the course of their lifetime. Maybe they're living in mold. Then they get bitten by the tick.
Mhm.
Then maybe they're still okay. Maybe their immune system is holding it together. They're having symptoms, but it's still not that bad. Then they, let's say, move to another location, and maybe it's mold, and it's maybe next to a golf course with pesticides that are sprayed, and maybe it's right. It's a layering event, and then it's like we call it. There's an initiating event that's earlier that keeps this going up, and then there's like then the mast cells are sensitized, and now they're going to break through. I think about it. I love Dr. Claudia Miller has this beautiful she's an expert in tilt or toxic and induced
Yes.
loss of tolerance. And she has a slide. She just presented with me at iLads. She's incredible with her research. And she shows this iceberg, basically like the mast cells are getting exposed, and they're under the water, and then it just breaks through because it
Yeah.
just can't hold it
Yeah.
anymore. So I
Yeah.
think what's important to note is that when people have, let's say, food sensitivities, and they only have three foods, it's not the food that is necessarily causing their mast cell
Yeah.
activation syndrome to start. It's the food that's causing the mast cell activation syndrome to continue.
Yes.
Once they're in
Yes.
that,
Hmm. Yeah, they're
that,
primed, which is exactly what you're describing. And
mm,
then that priming, then they are like, I was thinking of it as like angry, hungry wolves, right? And when the wolves are angry and hungry, there's not much that will take. It's a little tiny, something that triggers them, and they're very reactive.
yeah, yeah, exactly. So I think we need to look at the initiators
Mhm.
on one hand, and then we have to look at the triggers on the other hand. Because I think that while the initiators could be triggers, I think about it a little bit differently.
Yeah.
So the initiators are things like infections.
Yeah.
And again, there has to be a predisposition. I,
Yes.
I
We have this
don't.
genetic foundation because some people, no matter how many infections or toxins or COVID times they get, they're going to be fine. And then others are very prone because of the genetics, which there's 101 different things that can play into that. There's not just one gene, although there is a KIT gene. We could talk about that a little bit. There's one in particular that makes
Yeah,
people very prone to that. There's others too, but that makes them very prone to this. And then, like you said, some of them kind of go down that line. So
yeah.
initiators can be infections.
Could be infections, could be, again, toxins from the environment. Mold is high up on the list. I agree with you. If not what number one, definitely the top
Yeah.
three. Organophosphate,
Hmm.
pesticides,
Yeah.
implants
Yes.
are
So
very,
I see a lot of people in the chat mentioning breast implants. Absolutely. Even if they don't leak, this foreign material in your chest for many
hmm.
people is a trigger.
Mesh from like hernia surgeries.
Hmm.
We have kids who have the hernia surgery, in the first year or two of life, with they have some kind of mesh put in, and then they go on to develop all these chronic issues, right? And you don't realize that that's kind of where it started.
Started, right.
So again, lots of different things in our environment, plastics, right? We have glyphosate. I mean, the list goes on. I can keep going. And then, again, once the mast cells are primed, and then over time, they continue to be primed, right? That you get another infection,
Hmm.
you get another assault. I think someone mentioned that they moved into a new home
Hmm.
or there was reconstruction on the home. All those materials
Yeah.
that are being used to build homes, highly toxic. And I
Mhm.
definitely have patients who have had problems with that. So then what happens is then it gets to a point for a lot of patients where their mast cells are so dysfunctional, from all those events, that then little things that shouldn't even affect them, like the sun, like
Yeah.
heat, like EMFs,
Mhm.
like things that don't, like a lot of other people don't have a problem with, start to like sort of compound the problem. And so somebody here is saying, as asking, well, if you have all these assaults, essentially, what can you do about it, right? And we're gonna talk about it, right? I
Yes.
I, I know like painting a very negative picture, but the reality is that no, you can't reverse all those things that happened before, but you can
Yes.
get the body into a state where the mast cells are calmed,
Yes.
stable, and less reactive to the environment.
Oh, good. This is so good. So let's go now. Let's shift into starting to do the solutions. And again, guys, hang in because I promise we'll get to GLP-1s, but I want to first cover the basics because GLP-1s, we're talking about experimental therapies. We're talking about something that is not FDA approved. And we will talk about that. And we'll talk about what we've seen in clinical case studies. But this is very new. And for any great scientist just first observes. And I think both Dr. Dempsey and I and all the authors of the article and anyone in this field is just observing there's something unique here about that. But again, stay tuned. Before we jump into that, I want to talk about basics. We've got lots of nutrition. Well, first of all, let's overarch here. Very first thing I always think about is our limbic system. Mast cells are these primordial things that are protecting us. And there is always some component of limbic activation, whether, you've had trauma or not, that I feel like we need to address. And there's a million and one programs out there, Primal Trust, DNRS, Annie Hopper's program, Gupta's program, and then vagal nerve stimulators. And all that is, I don't want to ever lose that because I
Oh,
have referrals and people that I know you and I both use for those programs. So those are available, and those should be part of any person's program who's suffering from mast cell. But I don't want to spend today, we only have an hour on all of that. I just want to say that's really important to address the limbic system. And then we'll talk about herbal, natural things, and then we'll talk about drugs. Before we do that, do you want to mention anything about limbic system, and then we'll talk about herbals?
Yeah, I think it's critical. I was fortunate to speak to Dr. Neil Nathan this weekend too at our ILADS
Mhm.
conference, and he gave a great talk on mold, and he covers the limbic system at
Mhm.
great length. And it was funny when I presented some of the cases afterwards. He would come over and he goes, "Did you make sure first? Did you make sure they were tested for mold? Did you make sure you were
Yeah,
doing
right.
retraining?" And
He's
I was
always
like,
on there.
"Yes,
Limbic system. Yeah, of course, right.
course, I was just trying to get the case
Yeah.
what I was doing." But
Yeah.
yes, but the reality is that he's so right. Like that is a critical piece.
Mhm.
Sometimes you can't even go in with herbs or meds until that nervous system is addressed.
Mhm.
Often patients not only have limbic activity, increased limbic activity, but they also have sympathetic
Yes.
nervous
Yes.
system activity,
Mhm.
right? You mentioned the vagal nerve.
Yeah.
So vagal nerve dysfunction, the
Mhm.
parasympathetic nervous system is not kicking in, and that leads to the digestive issues you see in a lot of other symptoms, right? If you're in sympathetic drive all the time, the mast cells which are lining the nerves throughout
Mhm.
the body are going to be constantly signaling with the nerves danger, danger, danger. And so then you're in this state of like trying to run from the bear chasing you.
Yes.
And so there are lots of different programs, and I agree with you. I mean, I think each program is a little bit different. I
Yeah.
always tell patients, just go on the websites and read about it, see what
Yeah, try
resonates
it
with
out. Yeah, because they're
you.
all different and not everyone likes. And I would say the most common out there are Annie Hopper's DNRS. I saw
Yeah.
people mention Dr. Gupta's program. I love Primal Trust. It's been my personal favorite. And then there's 101 other new ones out there. So if you find something, share it with people on the chat. And then things like, again, same thing, vagal nerve stimulator, some of the big ones out there, True Vega, Gamma Core, Pulsetto. And again, there's even things that you can do with just vagal nerve stimulation from gagging to gargling to gut microbiome
Humming,
humming.
singing,
Singing, yeah.
there are a variety of ways, little hacks. I think it's interesting. There's some research now. I mean, this is a little bit less um, accessible, but stellate ganglion blocks,
Yeah.
I think, are going to be really interesting
Yeah.
for those who, let's say, have tried a lot of these things and
Mhm.
not getting the results, because it's sort of helping the parasympathetics
Yeah.
get back online.
So then let's shift to like herbals because there's
Yeah,
obviously not a lot of great natural. I almost always start with the limbic and then some sort of natural. And then many times you can explain this as well. But there is a layered approach to most of my patients. There's never, I shouldn't say never, there's rarely one thing that completely fixes the problem. So maybe let's talk a little about herbals, the common herbals, and let's maybe do no more than 5 minutes because I want to get to GLP-1s and then Q&A, maybe
thank
even
you.
less, just a couple. Yeah.
Yeah. Um, so again, herbals can be good. I think that someone mentioned like DAO, like diamine oxidase, which is not an herbal, but would be considered a natural
Yeah.
supplement.
Yeah.
It's an enzyme that breaks down histamine for those who have histamine issues, who know that they have, let's say, GI symptoms
Mhm.
after eating. It's worth a try. It can
Yeah.
be life-changing for some, not effective at
Mhm.
all for others, not good for others, right? And that's the key point that I want to just drive home, that not everything that could be good for one person is going to be good for another person.
Mhm.
And so it is really individualized.
Mhm.
I want to talk a little bit about quercetin because
Yes.
that's a hot one that a lot of people talk about and certainly can be very, very helpful. It is a natural antihistamine and mast cell stabilizer. And but I will say there are a subset of people who probably either won't do well on it or try it and don't do well on it. Maybe it increases their anxiety, maybe it increases some symptoms. And I think that is the genetics. And I don't know if that the test you were talking about measures this, but the COMT enzyme,
Yeah.
catechol O
Mhm.
methyltransferase, is an enzyme that breaks down catecholamines.
Mhm.
So adrenaline, epinephrine, dopamine, norepinephrine, like lots of different, and even hormones.
Yes.
And there are some people who have a slower version of that enzyme. And so that enzyme um, doesn't break down those things well enough. So they wind up with higher levels
Hmm.
in their brain of various neurotransmitters and catecholamines. And if you, quercetin slows that enzyme down
Yeah.
even further. So that can, for some patients, exacerbate it.
Mhm.
Now, I will say, I have patients who have a slow COMT who do fine with
Yeah.
quercetin
Yeah.
because they have other enzymes that
Mhm.
compensate, right? So I'm not saying it's
And it
across.
depends on your adrenals. Years ago, I was high cortisol, high adrenaline, and quercetin would make me like wired. Now that I'm postmenopausal and my adrenals are a little bit more flat, I love quercetin. So it definitely depends on your lifestyle and your
Mhm.
underlying conditions. Let's talk briefly about meds, and then we'll talk about GLP-1.
Yeah, 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 yeah. So look, the meds are antihistamines, either
Mhm.
H1 or H2 or both
Mhm.
together. They have to be trialed one at a time. They're not interchangeable. So like today, for instance, I had a patient who was doing really well on Allegra and had unfortunately has an ALS type picture, has underlying infections, has severe lead toxicity.
Mhm.
Crazy. I've never seen lead levels this high. Has a lot of neurologic symptoms. We put her on Allegra. We're doing other things,
Yeah.
but the Allegra did she did notice something
Mhm.
positive with some of her symptoms, and she was taking 180 milligrams twice a day. So today we're going through the med list, and she said, "Oh, I'm taking antihistamines." And I said, "Whoa, whoa, whoa, wait. Are you taking Allegra like we've been,
Mhm.
like you've been doing?" And she said, "Oh no, my daughter bought me Claritin. I'm taking Claritin 10 milligrams once a day." Because I'm trying to figure out why she doesn't feel good now.
Yeah.
Like
Yeah.
something changed. She
Yeah.
said, "I'm getting weaker. I don't really notice anything. I think things are getting worse." And I'm thinking, whoa, 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 what changed? That's why we go through it, right? And so her family thought that it doesn't matter. You just go to the pharmacy and you just buy. It's a Claritin, Allegra, whatever. And it's not, right? It's very individual. Every single antihistamine
Mhm.
has a specific
Yeah.
effect on the person, right? And then we have things that block, let's say, leukotrienes. Those are often mediators that can cause respiratory issues, but can also affect the body systemically. So Montelukast or Singulair, Accolade, we have those. We have ketotifen, which is a mast cell
Yeah.
stabilizer. Low-dose naltrexone is a really nice, very interesting drug that we use a lot for mast cell activation syndrome, but also autoimmune issues, right? I like LDN because it
Yeah.
kind of kills a few birds with one stone. Anyway, the list goes on, right? There are lots of, I like to think about this as we have lots of options.
Yeah.
If you're not feeling well, you got to keep searching. But the other thing I'll mention, Dr. Joel, is that I think it's also important to keep looking at the triggers and the
Yes,
underlying
yes,
problem.
like you have to get root cause for sure. I love that. Okay, let's go into the GLP-1. The reason a lot of people came, because again, you
Yeah.
wrote the paper, and of course, Kyle will link that here if you guys want to read the actual case study reports. Why? So you can kind of frame it how you want because we've clinically been seeing this important anti-inflammatory effect of very small doses. Um, there's some mechanism that might explain that, but do you want to explain just a little bit about why we might be seeing this and why we're starting to, publish case studies on the effects of GLP-1s in mast cell?
So I think many of us came at this um, maybe similarly. I think it's interesting that some people started hearing others do it, like me,
Hmm.
hearing me do it, and that they're doing it. But I think there were lots of people who started to understand that there was something interesting about these drugs with our patients with inflammation. My first patient was a patient who probably 3, maybe 4 years ago, I was giving her, I think I started with Ozempic for actually probably Wegovy for weight
Hmm.
loss. And so she was, obesity. She met the criteria for the FDA. I started like I would with somebody who, needs to
Hmm.
lose weight, but she had underlying MCAS. She
Yeah.
has a history of Lyme, Bartonella, Babesia, Q fever, and a
Hmm.
bunch of other things. And then, but a lot of brain fog, and she has a history of a traumatic brain injury. So, I'm managing everything. We're doing everything, but she's like, look, I can't, I really need to lose weight, and I can't lose weight
Yeah.
probably from all the inflammatory conditions
Yes.
she
Right.
had, right?
Exactly.
So we put her on it, and she struggles a little bit in the beginning with the nausea, right? Then it like gets a little better. And then like literally almost overnight, she
Yeah.
says, my brain fog goes away
Yes.
within hours
Yes.
of that dosage.
Hmm.
And I'm thinking, really? Like
Yeah.
that fast? And I was like, I started getting the literature and I'm like, oh, interesting, right?
Yeah.
In mice models and in rodent models where we understand that it's anti-inflammatory, there's all this body of literature now looking at it for all these other conditions.
Hmm.
And they're looking at it for neurodegenerative diseases like Parkinson's and
Yeah.
MS. And I'm thinking, okay, she had traumatic brain injury 20 years ago. She has some sequelae from that. She has MCAS, she has Lyme, and we put her on this GLP-1 and it's like miraculous.
Yeah.
What's so interesting about her is that she actually hasn't lost as much weight as she would like,
Hmm.
maybe 5 pounds, maybe 10 pounds at most, at a pretty low dose. I think 5 milligrams or something. She can't go up. She has too many symptoms,
Yeah.
but she never wants to go off it because when she takes
Okay.
it, she can work.
Yeah.
She can function. She just feels different.
Better.
And so that was the start of me going, wait a second,
Mhm.
there's something
And Dr.
about,
Dempsey, exact same. I had a severe post-COVID, long COVID, a history of Lyme and infections and severe mast cell. And actually, her whole family had it. Same exact thing. She was pretty significantly obese, and we started on it for that reason. Same thing. She came back. She's like, this cured my mast cell. Like she was just like so adamant. And same thing. She definitely lost some weight, but it wasn't about the weight loss in the situation. She was like, no, I don't even care about the weight anymore. I feel so much better. So it's interesting because, and I think just like you and I, a lot of clinicians are like, okay, huh. Now, if you look in the research, mast cells have GLP-1 receptors,
they do.
and there is research on downregulation of NF kappa beta, TNF alpha, IL-6, some of these big inflammatory cytokines. So it kind of starts to make sense. So then when did you get together with your co-authors to actually say, let's publish some of these case studies and give us just a little taste? And maybe we, again, if we go till maybe 10 till or so, we can then jump on with questions, but I think we can get through this. This is so important. So maybe
Yeah.
give us a taste on some of those cases. You've given one of those and what this looks like. And one last thing I just want to mention, I know a lot of you on here are like, this didn't work for me. I felt so bad. GLP-1s are not for everyone. So I want to be so clear about this. This is not a one size fits all. We are not saying you should go out and take this without physician supervision. And this is off label. All we're saying is we're observing some unique effects on a subset of people. So if it doesn't work for you, it doesn't work for you. That's okay. And I want to kind of frame that because this is not for everyone. If you have side effects, you should not be on the drug, period.
Yeah. Thank you for saying that.
Yeah.
That's very, very important. Like everything else we've mentioned, things don't work for
Mhm.
everybody.
Right.
And there's financial considerations because some people need to get it through insurance, and if they don't meet the criteria
Yeah.
that the FDA has set for these
Hmm.
drugs, either diabetes for one set or weight loss for another set, it's going to be difficult. Now, again, we're talking about off-label use,
Yes.
compounding,
Yes.
microdosing.
Yes.
There are options. That's the point.
Mhm.
But it is, maybe not right for everybody. I do think that if you've tried a regular dosage and you had trouble, you might want to talk to your
Yes.
provider about maybe trying a microdose to see if it would be different. Okay, sometimes we see that. I had one patient who tried the 2.5 milligrams of Manjaro and got really, really sick. But then if we do a tenth of the dosage
Hmm.
or even
Yes.
less,
Yes.
maybe they actually they tolerated it. So it's again, it's different. Now, mast cells actually have GLP-1 receptors. They also have GIP
Hmm.
receptors. Okay. And those are the two incretins that tirzepatide
Hmm.
has. Semaglutide is just a GLP-1. So what happened was, I started having these cases, and we have a listserv, a group that we often, discuss cases, and we all started
Yeah.
throwing cases into the ring, like, oh, I just saw this, I just saw that, I just saw that. And Dr. Afrin, who is just I just love him. He's so research
Yeah.
oriented. He heard all these things and he said, well, why are we not publishing this?
Yeah.
He's seeing it, I'm seeing it. And he said, let's say how many people have cases that we can
Uh-huh.
contribute. And we found 47 cases. All of them had to meet the consensus two criteria for mast cell activation syndrome, right?
Mhm.
Otherwise, it doesn't
Yeah,
doesn't make sense to publish a paper called Utility of Glucagon-like Peptide 1 Receptor Agonists in Mast Cell Activation Syndrome. They all
right.
had to meet consensus two. So that was challenging because some providers in our group do not test or can test or have a lot of patients who, let's say, who
Mhm.
did
Yeah,
who
qualify for the.
qualify. So we really strict with that. And we wound up with, Dr. Afrin, myself, Lenny Weinstock, Svetlana Blichstein, who's a neurologist in University of Buffalo, and Jill Schofield, who's also in
Yeah,
Colorado.
she is my neighbor.
Yeah, right. And so we put our cases together and we started, doing some analysis and trying to understand what we were seeing. And we saw an 89% improvement
Wow.
amongst those patients.
Mm.
Um, Again, there are going to be patients who have less effects. There are going to be patients who
Mhm.
cannot tolerate, had to stop. There's lots of things to consider, but I think that I think it's promising. Again, anything that can bind to the mast cell that can potentially stabilize it is
Yeah.
promising. But anything that can bind to the mast cell can also set it off.
Yes.
So I do have a subset of patients who feel an increase in their mast cell symptoms after taking these drugs. And I think those are the people where the drug is binding to that receptor and sending a different signal.
Mhm. Yeah, I love
Just
that you said that because I really like, I mean, I wish it would work for everyone, but it's
yeah,
just not the case. And I see a lot of you in the comments who have tried and had side effects, and that just means that either the dose is wrong or it might not be for you. And of course, more research is needed, of course, but we're just, I feel like I love bringing things that are really on the cutting edge because you and I are out there seeing these patterns and we might as well start talking about it so that there gets to be more research. Um, well, it might be a good time to go to, first of all, thank you because you've been so good about this overview and so good at framing it.
Ooh,
We've got over 68 questions, so maybe we'll start to jump in
yeah,
to some
let's
of
do
those
it.
questions. And I can just kind of moderate this. I can pull them up and ask you and then, comment as well. And I'll try to
There's
just get.
something that you think you
Yeah.
want to insert,
Exactly.
please.
So in no
Yeah.
particular order, and guys, we'll do our very best to answer as many as possible. I will promise you that. I won't promise you we'll answer every one, but we may just have to come back and do this again. And many of you who just got on, this is recorded. You'll be getting a recording if you signed up. So don't worry if you missed part of it or just, came in and whatever. We will be sure and send that out to you afterwards. All right. So interesting. This is a great one. Alpha gal, which can be the reaction to beef. Is there any information on GLP-1 with alpha gal? I'm assuming no, but have you heard anything like that?
No, not yet, but I think it's promising. I think alpha-gal is a mast cell problem essentially, right? Because
Yeah.
it is an allergy to that carbohydrate in meat.
Hmm.
And um, if it's a IgE, allergic immunoglobulin that's produced, it's binding to the mast cell and sending that signal. So you would think that there's potential
Yeah.
for stabilizing the mast cell so that IgE won't bind. So I think it would be really interesting to start to evaluate that. Yeah,
I
because
think
it's a
we'll see
tough
so many
interval.
more things that, and maybe things that are related to mast cell that we didn't realize are related and are improving too. That, let's see, this person says tirzepatide versus semaglutide. You started to talk about the difference because one of them has two receptors, one of them has one. Are you seeing in your case studies one of them being more effective, or are they equally just different populations?
Yeah, a little bit different. I would say that anecdotally,
Mhm.
not so much from the research, tirzepatide, because of the dual agonist effect, that dual incretin effect, maybe is better stabilizing for many patients, and maybe more anti-inflammatory. But then, we always have the outliers, the people who really find one better than the other. They find the semaglutide better. And I just go with whatever,
Yeah,
whatever
works.
the patient feels, if typically now, a year ago, I was doing it a little differently, but now I start with tirzepatide. And if that doesn't seem to make a difference, then we go to the
Mhm.
semaglutide.
I would agree. I always start with the tirzepatide, and just like you, where there's a few, I would say maybe 80% do better on tirzepatide and 20% do better on semaglutide, but it is a little trial and error to figure it out. And if one doesn't work, I'll try a different class. I've even tried the old liraglutide, which is a daily, because it's a very
Yeah.
mild, very gentle, and for some people, a tiny dose of that. It's daily though, so they don't always love that. This is more on not GLP-1s, but mast cell. Lisa asked, how do you prioritize various mast cell treatments? You talked about H1 blockers, H2 blockers,
Yeah.
mast cell stabilizers, and that cromolyn, those things. Is there any order of operations when you're kind of going down the list?
I'm going to be honest. I wish we had an algorithm. I think about, when I was in med school and residency, we would learn about, let's say, a patient comes into the ER with chest pain.
Yeah.
If chest pain, you do the XYZ, you
Right.
follow the algorithm down, right? And there's almost no thinking involved.
Yes, you're right. And
Right.
yeah, mast cell's the opposite, isn't it?
The opposite.
Yeah.
I know, depending on the patient's symptoms,
Yeah.
H1, H2 blockers are typically, easy to start with, especially if we're waiting for labs to come back or whatever, right? So I default to that. But, really it's a lot of it's based on symptoms, what the
Mhm.
labs show. If somebody I got the labs back and it shows an elevated prostaglandin D2, leukotriene, then I might try to target those particular mediators on the hope that that would be the answer. Not always, unfortunately. So I just, I kind of work my way down with, generally speaking, H1, H2, and then the next set could be any of these.
Yeah.
LDN, ketotifen,
Yeah.
cromolyn, and maybe the leukotrienes. But maybe in there I've thrown in quercetin and maybe
Mhm.
in there luteolin or maybe, so again, this is really personalized medicine. That's why
Yeah.
I call my practice AIM Center for Personalized Medicine.
Absolutely. I couldn't agree more. H1, H2 are easy. They're over the counter. And so but then, like you said, it's trial and error and it's figuring out. And I will mention too, I know like my neighbor, Dr. Schofield, is an expert in this, and many of us who do mast cell, many times the excipients in the commercial versions are the problem. So you have to compound these, which makes
Right.
it extra difficult. Not everybody, but a lot of patients need the compounded versions of Zyrtec or of Pepcid or one of those. So Alyssa asked, this is a great question. If gut issues, autoimmune issues, or hormones could be triggers to the mast cell. I think you can speak to that, I'm sure.
I'm sorry, the question is, are
Gut issues like celiac or autoimmune, and then hormones, because I know hormones play a lot into mast cells in my patients.
oh, so are these things all
Triggers
like
or piece of
triggers?
the puzzle with someone with mast cell. Yeah.
Yeah, yeah, yeah. I mean, I'll just say yeah.
Yeah,
Like,
exactly, exactly.
yeah,
Yeah, and it's interesting. So menarche, perimenopause, and all these transitions post-pregnancy is a time when we see more autoimmunity and also more mast cell because of that transition in hormones. That's a whole nother webinar though, so I'll go.
I was just thinking that. Yeah,
Yeah, it's
exactly.
a really good one. Okay, mold exposure. Any particular treatments with mold exposure? Maybe I'll start a little answer to that because that's what I do all day long is mold exposure. The number one thing with a significant mold exposure is you have to get out of the exposure because there's no sense, dousing a fire if it's still burning or, like, or bailing out a leaky boat, you could say. So if someone really truly is in a house that has mold, you can remediate in some cases, you can leave, you can do all kinds of things, but you really need to take care of that root source because if someone truly has an ongoing mold exposure, all the mast cell treatments in the world will probably not quench that fire. Any thoughts, Dr. Dempsey?
Yeah, I no, you
Okay.
nailed it.
Uh,
Perfect.
okay, let's see. Guys, I'm just reading through here. Okay, everybody's asking about dosing, but we are very clear. We're not giving medical advice. We are talking microdosing, and that could be, like Dr. Dempsey said, up to or down to 1/10 of a dose, but we really can't give specific medical advice on this webinar, so you're not going to get that here. And I'm sorry, but it's at least you can talk to your doctors and you can read. There is again, a lot of the research is out there. Um, let's see, local mast cell specialist. That's kind of tricky. I mean, you really organizations like ILADS, which Dr. Dempsey's a part of, ICI, which is ISEAI, IFM, a lot of the functional trained doctors are starting to learn about this, but I would say this is a subset, maybe 10 to 20% of your integrated functional doctors even know how to treat this. Any thoughts on finding good doctors?
Yeah, yeah. Um, Trial and error, like
Yeah,
everything else.
I know. It just find
Yeah,
someone to
no,
listen to you at least. Yeah.
yeah. I think that any medical practitioner who has a curiosity
Mhm.
could potentially be the right person, even if they don't know about this.
Yeah.
I do peer-to-peers all the time to help support medical practitioners, doctors, nurses, PAs, whoever who are interested. They want to help the patient, but they just don't know enough about it. So don't discount those that
Yeah.
don't know directly, as long as they want to learn. great. We'll teach them, you know. I think that's the first step is like just finding compassionate people. You're not going to find those on a list, I
Yeah.
think.
Yeah.
But
Curiosity and compassion.
curiosity. And then, yes, I agree. You know, iLads is a great resource, but not everybody in iLads understands mast cell activation syndrome to the same degree, but they all happen to be much more open and are willing if they don't know. But I lecture a lot to that group, and so I hope they've learned from me. I think they
Yeah.
have. You know, I lectured on the GLP-1s and mast cell activation syndrome this at this iLads, so I think they're definitely onto it. And then, you know, we are within the next couple of weeks, we will have launched our website for our new mast cell organization. We are waiting for our 501
Mhm.
C3 designation. But we do have a mast cell organization, and that I hope will be able to put together lists for practitioners for patients, providing resources. So it's really exciting. Yes.
That is, because I think this is such an underserved population. I mean, every day I have patients who, have been everywhere and haven't had help. So I love that you're working on that, and me too in our spaces in the world. There's a couple just questions about triggers for mast cell. One is, could GLP-1s directly help like TNF alpha or some of these cytokines? I'm assuming the answer is maybe, right? Because we see that if they're looking at a direct lab value and seeing. And then another one is POTS. Have you seen any cases of, obviously POTS can be connected to mast cell activation, very frequently is. Have you had any cases of GLP-1s improving POTS and dysautonomia?
I have, absolutely. But I also want to make a point that the GLP-1s are known to, for some patients, to increase their heart rate.
Yes.
It's a known side effect.
Mhm.
That's one of the reasons, like 5 years ago, I was very hesitant to give these to my patients because I was so worried. I mean, what am I going to do with my POTS patients if I increase their heart rate even more, you know? So it is a consideration, but in reality, we often see improvements in that orthostatic intolerance that they have. So while their heart rate might go up a few points overall, their orthostatic intolerance and their heart rate changes in position actually improve. But not across the board. I definitely, one of the questions I got actually from the audience at iLads was this question exactly. Do you see it helping POTS? Do you see it making it worse? And she commented that she thought that tirzepatide helped her POTS, but then she tried, actually, there's a new drug called
Uh-huh.
retatrutide, which is in phase 3 trials right now, going to be approved by the FDA,
Mhm.
hopefully by 2026, but some compounding pharmacies are producing it. It's a triple agonist,
Mhm.
GLP-1, GIP, glucagon.
Mhm.
And she felt that the retatrutide actually helped her inflammation even more,
Mhm.
but it made her POTS a little worse. That was
Ah,
just an anecdotal report.
interesting.
So I think it is, again, going back to individualized, I think it has promise in POTS, but it may not work across the board.
Yeah, I would agree with you because of the heart rate increase that we frequently see. It's definitely not a one size fits all for the POTS, but some people could benefit. This is a great question. What blood test, since you wrote the consensus paper, can a family doc test for other than tryptase? Is there some things that are a little bit easier for them to run, or do they really, yeah, what would be like the easy list for a family doc for them to ask if they're wanting to get a diagnosis of mast cell activation?
You can do a plasma histamine, a whole blood histamine,
Mhm.
chromogranin A. Chromogranin A is not specific for mast cells, but a slight elevation may be enough to suggest it, especially combined with these other things. Tryptase is going to be almost always negative unless there's hereditary alpha tryptosemia, HAT, or mastocytosis, but that's a whole other conversation. Um, and then family doctor, what else can they test? You know, there are other markers. They're not in the consensus two. Like the consensus two is very clear, right? Heparin plus these ones that I just mentioned. Then the urinary random 24-hour collection for histamine metabolites like N-methylhistamine, prostaglandin D2, the prostaglandin metabolites, leukotrienes. Those can't be tested in the blood. So family doc, if they start with histamine, whole blood, plasma, chromogranin A, tryptase, just in
Hmm.
case. But then, again, reading off script here and not in our paper, some of these, like if you can measure VEGF,
Yeah.
we know VEGF is produced by mast cells, but it's not specific for it. You can measure some of these other, TNF alpha. There are labs that will measure, IL-6 and some of these other things. You could theoretically,
Hmm.
but I think they're more expensive and they're not as reliable in diagnosing mast cell activation syndrome.
Mm, thank you. Well, guys, so we are at the hour. This has been so fun. So, first of all, if you are on here, thank you for your patience and for joining us. It has been so great. I wish I could see all your faces, but it's fun to see the chat and see where you're from and all of your comments. And I just want to say from my heart to yours, I know that many of you are suffering, and I know that many of you have felt like unheard by the medical system. And I hope tonight is just, I know it's not a lot, but I hope it's just a tiny little bit of inspiration that there is hope and that there are doctors like Dr. Tania that really love what we do and love all of you and love to see people life change. Like there's just no greater feeling in my life than when I see someone turn around from something that they've been suffering for, some mystery diagnosis. So I think the biggest thing from us to you is thank you. Um, if you were on this here, you're going to get a recording. We will link up all kinds of resources for you in the email that follows. And I hope you guys, if you aren't already on our Instagram accounts, first of all, websites, drtaniadempsey.com and jillcarnahan.com. We both have tons of resources there that's free. So be sure and check that out. And then if you aren't on our Instagram accounts, pop in there because we also put tons of great information. And if you look way back, there was this interview we did in the middle of a snow store. I can't remember what it was, like lightning store. And we're in the car and we're both trying to do this thing. So if you can find that, you win like $100 or something.
That was funny. I know.
It
I
was, I
know.
remember that very much, but truly thank you all. I hope you've enjoyed this. I hope it was helpful and stay tuned because we'll probably be doing another episode. But thanks again, guys.
We have to. We
Yeah,
have
we have
to
to. Exactly.
now.
All right. Lots
Thank
of
you
love.
all. Thank
Take
you
care.
all.
Bye-bye.
Bye.